Welcome to One Step Endodontics, from diagnosis to treatment. Our lecturers are Dr. Brett Gilbert, Dr. Tom Jovicic, and Dr. Alan Deutsch.
Hello, my name is Dr. Brett Gilbert. I'm here to discuss with you a topic of the essentials of endodontic diagnosis. Endodontic diagnosis. Prior to initiating the diagnostic process for endodontic cases, a realistic risk assessment is really necessary. When you think of endodontics, risk does come to mind. It's very easy to get off on the wrong foot, to get off into the wrong direction, and wind up in a situation where you're uncomfortable, and therefore it could lead to more of a procedural accident or incident. And very important to really be able to assess what the case is prior to beginning. Once endodontic treatment is initiated, you have to be prepared to handle these adverse incidents. Having a plan in place for what to say and do, as well as how to react and proceed when tackling an adverse incident, will really help alleviate a situation in which the patient could lose confidence in the treating clinician's abilities. So never, never, never start treatment without a definitive diagnosis. Back to key points. After completing this portion of the lecture, the learner should be familiar with the following: the set of clinical tests used to develop a definitive endodontic diagnosis, the importance of the clinician's interpretation of the test, and the importance of putting all pieces of the diagnostic puzzle together to arrive at the definitive diagnosis. If you are unclear on these points, please go back and review the previous slides. Nomenclature. So when we look at making a proper diagnosis for endodontics, you really have to compose a pulpal and a periapical diagnosis. And really, the proper documentation of your pulpal and periapical diagnostic terminology as set forth by the American Board of Endodontics will provide you the proper medical legal charting that you really need to be able to legally justify the treatment you've provided to your patients. I thank you for your participation in this course. I certainly hope that it's something that may be helpful to you clinically at the chair side. And again, just encourage you to really think through the whole procedure and recognizing that the first step is the most important step.
Hello, my name is Tom Jovicic. I'm an endodontist. I'm here today to talk to you about endodontics. This course that we'll be dealing with is regarding diagnosis and treatment planning. The first thing everyone sees is the number of lateral canals that are in the slide. But if you look at this and break this down even further, what you can see is pretty simple. In looking at this slide, you can basically see that the canal diameter was already made for you, obturating the canal in a vertical three-dimensional manner. The key component to any kind of endodontic treatment is an accurate diagnosis. Treatment plan. It's important, again, that you take this information, put it all together, and present it in a manner to the patient that gives an environment where the clinician to determine if the pulp is in three states: normal, inflamed, or necrotic. That we have the technology today at our hand that has been created that offers us a reliable, a repeatable, and most importantly, a consistent method of treatment. So when you see this slide, you're basically looking at all the possible anatomical variations. And what you're looking for are additional canals. You can see the anastomoses, and you can actually see the lateral canals. We talk about all portals of exit. If you start at the top of the tooth and go to the bottom of the tooth, every one of those things that you see is a portal of exit. And because it's a portal of exit, you have to be able to account for it. Thank you, Dr. Tom Jovicic.
Hello, my name is Alan Deutsch, and today we're going to be talking about anterior endodontics for the general practitioner. I thought our success rate would increase just as long as I practice. In other words, the more years in practice, the better the success would get. But it didn't quite work like that. The red line represented what I thought would happen. The reality was it came in discrete little bunches, and it came every time we changed techniques in our office. Try to do the treatment when the tooth is still vital. Now, conventional treatment versus non-surgical retreatment. What we found here is that on average, around the world, root canal is about 92% successful. If you retreat it, it's about 88% successful. If the retreatment doesn't work, if you do an apico, it's roughly 75%. If you're using the microscope, the percentage does go up. If you do an implant, it's roughly 92% successful. And what will happen, that patient will have a tremendous amount of postoperative pain. You'll get a telephone call late at night, and the patient will tell you, as soon as the anesthesia wore off, it started to hurt me. That's usually pathognomonic indication of over-instrumentation. So here you can see a little movie of the mirror, and the bottom part is the rhodium, which is a little darker on this split mirror, and the top part is tantalum pentoxide, which is a reflective coating. It increases the reflection dramatically. Here's a picture of the anatomic apex and the radiographic apex. Consequently, you're not going in a circle, so you eliminate cyclic fatigue, and which is a big contributor of breakage. Now, the cyclic motion also happens in a 30-degree plane. An interesting thing happens. It doesn't go into the periapical area. It actually tends to go into the lateral canals. And that's because of the design of the spiral. You readily see the lower apical and lateral canal that was filled with the sealer. I hope you enjoyed this presentation today. We took you through a lot of endodontics, from access openings to filling canals to irrigation. And I'm sure if you follow some of these hints and benefits, you'll enjoy a higher success rate in your anterior endodontics.